This is the third in a series of presentations on the topic of disorders predominantly affecting the diaphysis, metaphysis, and physis in our veterinary patients. This presentation is going to talk about the radiographic appearance of bone infection, and by the end of the presentation, I want you to be able to recognize and describe the radiographic findings of bacterial osteomyelitis and fungal osteomyelitis. And we're also going to talk about something called sequestration formation that is predominantly seen with bacterial osteomyelitis. Soft tissue disease from injury or trauma or inflammation, cellulitis, may be present without bone infection, but in patients with clinical soft tissue disease, radiographs are beneficial to assess for any osseous or joint involvement, as well as to assess for foreign material, and should be considered, especially if the patient has had chronic soft tissue swelling or discharge. In addition to radiographs, further imaging with ultrasound, CT, MRI, or even scintigraphy may be beneficial. This is a horse that has a laceration that is fairly acute on the metacarpus, and so radiographs were obtained to assess for amount of damage and for any osseous injury. We can see that there's quite a bit of soft tissue swelling here on this patient, predominantly at the palmar and palmar lateral aspect. Within the soft tissues, extensive gas, so subcutaneous emphysema, as well as small areas of fragments that are mineral opaque, so probably embedded debris. Patient also has some soft tissue swelling without gas on the dorsal aspect, and then some of the gas even extends up toward the carpus, probably not within the joint, but radiographs could be used to assess for joint involvement as well. In this patient, the bony structures are normal, so no osseous trauma at this point. However, it is not uncommon for the bones to be infected later or to actually be affected in a different way. And so it's really important to consider radiographing the bones of the affected area again in maybe 2 to 3 weeks, because if you remember, when we start to see bone involvement, it takes at least 5 to 7 days when we first want to identify lysis, and it can take up to 10 to 14 days to identify periosteoreactions. Therefore, it's going to take us radiographically at least a week to identify any osteomyelitis that has occurred at the time of trauma, because the radiographs will lag what's happening. For example, if you wanted to do some alternate imaging, say with scintigraphy, scintigraphy can actually identify osteomyelitis within 24 hours. Here's a dog that's presenting with distal limb swelling after trauma. And we can see that there's quite a bit of soft tissue swelling that is around the distal antebrachium carpus as well as the metacarpus. And then within the palmar soft tissues, we can see lots of little areas of gas, so subcutaneous emphysema. We could look for any foreign bodies. And in fact, some of this linear appearing radiolucency could potentially be a radiolucent stick that is embedded, and so we may need to assess further with, say, ultrasound to look for foreign object. But then we may be able to identify actual bone involvement through infection. And so I want to start out talking about bacterial infection of bone. And the term for infection of bone is osteomyelitis. It refers to infection of both the cortex and the medullary region, so osteomyelitis. And that can occur in different means. It can occur through direct inoculation, so that might be from a direct puncture, an open fracture, a bite wound, or even sometimes iatrogenic through our surgery. Bones can also become infected from extension through soft tissue infection, or they can be infected through hematogenous dissemination, so in a patient that has sepsis. Certainly any age can be affected with bone infection. If we're looking at the patients that have hematogenous dissemination, it's going to be more likely in neonates, and in fact, more likely in our large animal patients, so calves and foals, although puppies and kittens can also be affected hematogenously. Also, when it's hematogenous, the infection usually affects multiple sites, in different limbs, different bones. and typically will affect the metaphyseal, physeal, and epiphyseal locations, and that's due to the rich capillary network that's in that area. When we have a direct inoculation or extension of infection from soft tissues, then typically we're looking at just a regional infection. It may be more than one bone, but it's really going to be just one site. And then, as I said, any species can be affected, although our large animal patients may be more likely to have bacterial osteomyelitis than our small animal patients. When we look at radiographs, the findings that we might see of bacterial infection are typically more non-aggressive or semi-aggressive changes. And so that will be both our periosteoreaction, so we may be seeing solid or palisading types of periosteoreaction. Our lysis, if present, is usually mild. It may be variable and affecting predominantly just the cortex, although if it's hematogenous in a young patient, it might affect near the physis, so that's not necessarily the cortex. It might be deeper within the bone. And then oftentimes we have soft tissue swelling, and then depending upon how the infection started, you could see gas or foreign material within your soft tissues. So this is a horse to the right of the slide that had soft tissue laceration, so traumatic episode, probably several weeks prior. So we can see this irregular soft tissue swelling. There's actually a defect in the skin, so a cutaneous defect with some gas dissecting deep into the soft tissues. And when we look at the regional third metatarsal bone, there's quite a bit of very solid and opaque periosteoreaction with some areas of more irregular, almost palisading periosteoreaction. And really, it's kind of looking like the cortex is just really thick. And this is pretty chronic because it's pretty opaque bone. So this would be osteomyelitis secondary to an open wound or laceration. Here are orthogonal views of the anabrachium of a 7-month-old dog who had hematogenous spread of bacterial infection. And in this patient, it's affecting the ulna. When I look at the lateral view of the ulna, I can see some medullary sclerosis, as well as kind of a solid periosteoreaction on the caudal cortex. And then as we move down towards the metaphysis, there's actually a region of kind of geographic lysis adjacent to the physis, and maybe some permeative lysis of the cortex here. That shows up better on this orthogonal view where we can actually see cortical lysis. And in fact, in the mid-diaphysis, there's a larger kind of geographic area of cortical lysis as well. So this is hematogenous bacterial osteomyelitis. And in this patient, later a second site was identified in the pelvic limb, and again, just kind of showing us that polyostotic or multiple site nature. Now, I do want to call attention to the fact that we would not want to confuse this medullary sclerosis with panosteitis, which we've already learned about. Panosteitis would not have associated cortical lysis. We also wouldn't want to confuse this area of lysis in the metaphysis with hypertrophic osteodystrophy. If you remember, that would be a transverse lucent zone that's paralleling the physis. It also would not have this other associated lysis like this patient has. So we shouldn't confuse this patient with those other two growth disturbances. Now, here's an example of a calf that has extensive bacterial osteomyelitis affecting the femur. This patient had a femoral fracture that had internal fixation. The implants have been removed because of the development of infection. So this would be the area of the fracture in the mid-diaphysis, but what we can see is there is very extensive, irregular periosteoreaction that's going well beyond the site of the fracture. And then as far as lysis, the femoral neck and femoral head have extensive lysis related to this severe bacterial infection. Here is a tarsus in an adult horse, and this patient has some mild changes associated with osteomyelitis affecting the calcaneus. On this oblique view of the calcaneus, we can see some kind of permeative or punctate lysis involving the plantarolateral cortex. This view is a special flex tarsus skyline view of the calcaneal tuberosity. And again, we can kind of see these areas of permeative or punctate lysis in the cortex. Here's a little bit larger area of cortical lysis. And then this patient has extensive soft tissue swelling surrounding the tuberosity here. And this patient had a bursal infection that then spread to the calcaneus. Here is a calf that had hematogenous osteomyelitis that was involving the physis of the fused third and fourth metacarpal bone. So this is our fused third and fourth metacarpal bone. If we look at the physis, it's quite a bit of widening and lucency. We wouldn't want to confuse this with physeal dysplasia, which we learned about affecting the young horse, not the calf, not the cow, and especially because if we look more closely, we can see these areas of lysis that also affect the epiphyses. This patient probably has a pathologic fracture, but also has some periosteal proliferation and then extensive soft tissue swelling as well. So this is septic physitis that spread from the physis probably then into the epiphysis as well. Now, one thing you might have noticed as we've looked at these different examples, we've seen a dog, a calf, horse, adult horse, is that there have been varying amounts of periosteal proliferation. And the amount of periosteal proliferation is not only dependent upon the severity of the infection, but it can also be quite dependent upon the age and species. So you might have noticed that the calves seem to produce a lot of new bone, especially that femoral fracture that we saw, whereas adult horses oftentimes have very little periosteal proliferation. And then the other species and other ages are kind of in between. It also will be dependent upon the bone involved, as we'll see in this slide. And I specifically am going to draw out some bones of the horse. And these bones have very rudimentary periosteum. So when they get infected, we can see lysis in those bones, but we'll see very little periosteal proliferation. So those bones include the proximal sesamoid. So this is a fetlock. This is kind of an oblique view separating out the two sesamoids. And this one is infected and we can see geographic lysis, but we don't see any periosteal reaction. And that's very common when that bone gets infected. In the middle of the slide here is our distal phalanx, and again, this bone has very rudimentary periosteum, so when it gets infected, we oftentimes see focal lysis or resorption, but no periosteal reaction. And then the last bone to call out is our distal sesamoid, or the navicular bone. Again, when it's infected like this horse, we can find geographic lysis, but we will see very little, if any, periosteal reaction. I do want to speak a little bit more specifically on the distal phalanx of the horse when it gets infected, predominantly the horse, but certainly large animal, not horse, so cows can have this as well. And when the distal phalanx is infected, we are going to term it septic pedal osteitis. Instead of the term osteomyelitis, we use osteitis because the distal phalanx doesn't have really any medullary cavity to speak of. So we're really only talking about kind of the cortical bone being infected. Pedal, because that's the pedal bone, the distal phalanx. And then we're going to use the term septic because there is a non-infectious disorder of the distal phalanx of the horse called just pedal osteitis. So I want you to put all of those terms together when we think the distal phalanx is infected. This can occur secondary to penetrating trauma, or it can extend from a sole abscess. And radiographically then, we're really going to see only lysis because we've just learned that the distal phalanx has a rudimentary periosteum. So we typically find kind of discrete area of lysis. It's oftentimes affecting the solar margin, so it might be an irregular solar margin with decreased opacity, which is due to the resorption. And then we may be able to find adjacent gas in the sole, either if there was penetrating trauma or if there is a gas-producing organism in the sole abscess. So this first example is of a horse. I have a lateral view and the 65-degree dorsal palmar oblique view. In the lateral view, there is this area of gas that is in the toe of the hoof, but the distal phalanx looks pretty normal because our lesion is going to be pretty focal. So on this oblique view, which is one of the really important views of the distal phalanx, we can see that there is focal resorption here, or lysis, in the lateral toe. And I know it's lateral because, again, the L is the left limb marker that is placed at the lateral aspect. Remember, on midline in some horses, usually bilaterally symmetric, you'll have this little indentation, which is our normal crina or crenna. We can also see that linear gas here in the sole that is adjacent to where that focal lysis is. So this patient either had a penetrating trauma or kind of a more extensive sole abscess, and now it has associated septic pedal osteitis. Here's another patient. We have a horizontal beam DP view of the phalanges, the distal phalanx, and then we have our 65-degree dorsal palmar oblique view. This patient, they left on the shoe and the nails, probably trying to support the hoof. And in this patient, there is a large hoof crack here in the lateral aspect of this hoof. The distal phalanx and the other phalanges look pretty normal on this view. When we look at the 65-degree DP oblique view, along the same side, that lateral side where that hoof crack is, there is a focal area of lysis in the kind of palmar process here of the distal phalanx. So that is our area of septic pedal osteitis. Here's an example of septic pedal osteitis in a young calf. This calf had trauma to the claws. And on the lateral and DP views here, I want you to look at these distal phalanges. Both of them are abnormal. Lots of lysis involving kind of the toe area here. Some of the lysis is kind of more punctate permeative, some of it's more geographic. Now, associated with this lytic process in both the third and fourth digits of the distal phalanx, there are associated pathologic fractures. So that's what these small fragments are. And then this patient has fairly extensive soft tissue swelling that is extending proximally up the digits. And the reason it is proximal to the area of infection here is because the hoof capsule can't swell, so the soft tissue swelling has to go proximally. So this is a pretty extensive infection. And in fact, sometimes, especially in cows and calves, when they get septic pedal osteitis, it's also involving the joints as well. Another thing that can happen associated with bacterial infection is a process of sequestrum formation. It is not uncommon to see this, especially in our horses or other large animal patients. How this happens is that at the time of trauma to the soft tissues and the bone, the periosteum of that bone can become disrupted or traumatized. And it can actually be like lifted away from the cortex. That periosteum supplies blood to the outer third of the cortex. And so if that blood supply is removed or damaged, then that piece of cortex can actually die. And when it dies, that is what is known as the sequestrum. Then at the time of trauma, there was usually simultaneous bacterial inoculation. So then you have this setup for bacterial osteomyelitis and the sequestrum. And then that sequestrum actually can't have any blood supply, so there's no way for it to, get any antibiotic delivery. And so oftentimes the bacteria like to live on that sequestrum. It's kind of like a little life raft for them. And then because of that, oftentimes surgical removal is needed. So radiographically, what we're going to look for is we're going to look for this very opaque, as opaque as the parent cortex, and sharply marginated piece of bone that is associated with the cortex. And then typically there is a surrounding region of lucency. So the sharply marginated piece of bone is our sequestrum. The surrounding region of lucency is like necrotic, tissue and pus. That doesn't have a name. But then the bone around it, where the kind of sequestrum had come from, can actually have both periosteal reaction or a sclerotic rim. So remember, increased bone opacity within the bone. And that is termed the involucrum. There can then be a disruption in that periosteal reaction or that sclerotic rim, and that allows for that necrotic debris in the pus to kind of drain out. That is termed the cloaca, so an interruption there. And then, of course, we're going to have our additional findings we've already talked about of osteomyelitis, so variable periosteal reactions and cortical lysis that's typically mild, and then associated soft tissue swelling. Now, we are going to focus on looking for the sequestrum. It is not uncommon to not identify involucrum and cloaca, so I really want you to focus on sequestrum. And whenever we are concerned about bacterial osteomyelitis in our large animal patients particularly, really be sure to continue to assess your radiographs for signs of sequestrum formation. Here's an example of a calf that has extensive bacterial osteomyelitis and sequestrum formation. So in the middle of the slide is the unlabeled DP view of the fused third and fourth metacarpal bone. Hopefully you can appreciate there is extensive periosteal reaction here. Some of it is lamellar, some of it's a little bit more irregular, so it's a semi-aggressive periosteal reaction. It is probably circumferential, which is why there's kind of this mottled opacity. So we're probably seeing superimposed periosteal reaction over the rest of the bone. And then when we look at this cortex, it's not labeled, so I don't know which side is which. There is a very discretely marginated, very opaque piece of bone with an associated defect in the cortex. So this is our lucent zone surrounding it. So this is our sequestrum. We have that lucent zone that's necrotic tissue and pus. And then there is more sclerotic bone or rim around that defect. That would be our involucrum. And then if you look in this periosteal reaction at the level of the sequestrum, there's actually kind of this lucent zone that has less periosteal reaction. That would be a cloaca. So this patient has all of our findings: sequestrum, the involucrum, and the cloaca. Now these metal things here, these are actually needles that they were using to mark for surgical intervention because they need to take out this large sequestrum. So this patient has had osteomyelitis for quite a bit of time because this periosteal reaction is pretty chronic and pretty extensive. Now here's an adult horse in the middle of the slide. I have a DP view and one of the oblique views. This patient had a puncture wound a few weeks ago and is presenting for persistent swelling at the level of the puncture wound. And we can see that soft tissue swelling here at this side of the metacarpal bone. If we look closely at the level of that soft tissue swelling, remember the soft tissue swelling can help us find our orthopedic disease, I do see this very faint periosteal reaction. So it's more of an acute or not as old periosteal reaction. That periosteal reaction, however, isn't kind of uniform. It kind of is interrupted here in the middle. And so if I look closely where it's interrupted, there is a small round or oval piece of bone with a very thin radiolucency around it. It's a little bit harder to see, but on this oblique view, again, I can see that small piece of bone and I can see a thin region of radiolucency. So this is our sequestrum. And then it has the associated bacterial osteomyelitis with the periosteal reaction, and then associated soft tissue swelling. This is probably the cloaca where there's interrupted periosteal reaction. So we have a sequestrum and a cloaca. I probably don't see an involucrum in this patient. This slide shows examples, two more examples of bacterial osteomyelitis with sequestrum formation. This is a tarsus of an adult horse. This patient had extensive soft tissue trauma with very irregular soft tissue swelling, probably a cutaneous wound because it looks more of a defect in this area. This happened several weeks ago. The patient was probably presenting with continued drainage and not healing wound here. And when we look at the third metatarsal bone, there is an area of kind of mild lucency in the cortex, but then this very opaque piece of separate bone that is at the level of that lucency, and then a little bit of periosteo reaction also surrounding that lucency. And so this is a very dead piece of bone. So this is our sequestrum with associated bacterial osteomyelitis, and then soft tissue swelling. That's probably the non-healing wound, as well as some granulation tissue. On the right of the slide is actually a dog. So although it is more common in large animal patients, our small animal patients can develop sequestra. This is the tibia. This is a kind of flex tarsal view, so we can't see the calcaneal tuberosity like we usually do, and that's because this patient had contracture and actually couldn't extend the tarsus. In the tibia, there's quite a bit of periosteo reaction along this medial cortex. And then in the medial cortex focally, there is a defect, and that radiolucency here, that zone of lucency, is surrounding this very opaque piece of bone. So this is our sequestrum. We have that kind of lucency. I don't know that I really see an involucrum, but this periosteo reaction here is actually kind of interrupted at the level of the arrow, so that's probably our cloaca. So bacterial osteomyelitis, and then quite a bit of soft tissue swelling, which is probably granulation tissue and cellulitis. So let's finish up this presentation talking about fungal infection of the bone, or fungal osteomyelitis. In our veterinary patients, this predominantly affects dogs and is generally hematogenous in origin following respiratory infection, although it can occur through direct inoculation. Our patients oftentimes have other systemic illness when they have fungal osteomyelitis, so they might have their fungal pneumonia, lymphadenopathy, and fever. Fungal osteomyelitis, especially when it's hematogenous, oftentimes has a polyostotic distribution in the appendicular and potentially the axial skeleton. It occurs in geographic regions where fungal infection is endemic. So in the Midwest and Southeast, it's typically with blastomycosis. And in the Southwest and West, it's typically with coccidioidomycosis. It can affect any age dog in any breed, but it is often the young adult and large breed dogs that spend a lot of time outdoors. So for example, hunting dogs, but it can be in any patient that might spend a lot of times outdoors at the cabin and lake where blastomycosis infection may occur. When we look at the radiographic findings of fungal osteomyelitis, especially compared to bacterial osteomyelitis, this tends to be a pretty aggressive looking lesion. So oftentimes, it does like to occur in the metaphyseal location, and that is because of that rich capillary network that's there, although it can happen in any parts of the bone. It is oftentimes polyostotic, as I said, since it's hematogenously spread. And then we're going to look for patterns of semi-aggressive to aggressive periosteo reactions and aggressive lysis. So again, this is going to be an aggressive appearing lesion, and we have talked about what those aggressive lesions might look like in previous presentation. And then there may be adjacent sclerosis as the body is trying to wall off or fight the infection, and then more often than not, there will be quite a bit of soft tissue swelling. So here's an example of a dog. I've got orthogonal views of the distal anabrachium and the carpus that has fungal osteomyelitis. And I want you to notice that this is a pretty aggressive looking lesion. So starting with the radius here, we have quite a bit of moth-eaten and permeative lysis throughout the distal diaphysis, metaphysis, and actually into the epiphysis. And there is cortical lysis as well. So those are indications of aggressive lysis. And then this patient also has kind of spiculated and palisading periosteo reaction affecting the radius. And so that is a semi-aggressive to aggressive with the spiculated reaction. And then notice this is polyostotic because there is actually lysis affecting the intermedial radial bone here, the carpal bone, and then very extensive soft tissue swelling that probably is not only extracapsular but intracapsular as well, so that joint may also be involved. Here's a patient with a less aggressive looking lesion. This is a young German Shorthair Pointer that has coccidioidomycosis affecting the mid-diaphysis of the ulna. This is a blown-up view of that ulna, and what we see is more of a geographic area of lysis, so a more non-aggressive pattern of lysis, and then surrounding kind of solid to lamellar periosteo reaction. So this lesion again is more of a semi-aggressive lesion, but this is also a fungal infection. And then here's a patient that has fungal osteomyelitis, blastomycosis that is involving the metacarpus. This is a 3-year-old Labrador Retriever. And if you look at the second, the fourth, and the fifth metacarpal bones, you can see this kind of mixed moth-eaten to permeative areas of lysis with cortical lysis, as well as some irregular periosteo reaction. And then there's mild associated soft tissue swelling. So polyostotic lesion with aggressive patterns of lysis. I guess I do have one more example. This is an 11-month-old dog that has blastomycosis osteomyelitis affecting the olecranon. And so this one has kind of a permeative lysis involving the cortex as well, and then associated soft tissue swelling. There is sclerosis, but not as much periosteo reaction. Be sure to consult the textbooks here to see more examples, as well as to read more about both bacterial and fungal osteomyelitis, and also to read more about sequestration formation. And in chapter 1 of clinical radiology, the horse, you'll be able to have a nice discussion of that to kind of round out our presentation.